Get started. Well, good afternoon, ladies and gentlemen. My name is Mark Perino. I serve as the president of the American Association for the Treatment of Opioid Dependence. And I am delighted to welcome our two colleagues from SAMHSA so they can discuss their recently released regulations. And the regulations were released last month. They do have an implementation of April the 2nd with a full operational sector of October 2024. Now, this webinar will give you the overview of the rule changes. It should assist you in determining what you need to do to prepare. Now, this will focus on the more general issues today. Next Wednesday on the 27th, there'll be a greater focus on the medical clinical issues. And what I said earlier is if you have any difficulty during the course of this webinar, you can contact Angelina Budia, and that email, all lowercase, is angelina.budia, B-U-D-I-J-A, @atod.org, or you call at 201-218-8030. And I expect that if you're typically connecting to webinars through your computer, just check to make sure that your speakers are working, obviously. So I'm going to introduce both Dr. Olson and Dr. Juliana very soon, but a couple of things. From our point of view, as an association, and we are in fact the regulated party, we think very highly of these new changes. We think they're broad. We think they provide much greater clinical flexibility, and it does reflect the most significant change since SAMHSA got this regulatory authority in 2001. Additionally, that I think very strongly that this gives OTPs the opportunity to reframe how we provide treatment to our patients. There are just over 2,100 OTPs in the United States, treating 650,000 patients. So we have a responsibility. And once the patient crosses the threshold, it's our obligation, both clinically and from an ethical point of view, to treat the patient with understanding and compassion. And in my view, these regulations really do reframe how we can provide that care. And you'll hear me say this throughout this period. And, just because we're doing this webinar today and next Wednesday, there will be opportunities for more information sharing and more webinars. SAMHSA, in my estimate, is keenly aware of how it's necessary to provide guidance to our field, not just the publication, but the guidance and implementation. And they are aware, and both of these people have come out of a treatment program environment. They're knowledgeable, they're completely grounded, and I have tremendous respect for both of them. So with that, it's my pleasure to introduce Dr. Olson to you. She is the director for the Center for Substance Abuse Treatment within SAMHSA. And then we will introduce Dr. Juliana. So Dr. Olson, welcome, and thank you for doing this.
Great. Thank you so much, Mark, and thank you for that kind introduction. And I don't know if folks are seeing the slides themselves or that we have. I'm seeing kind of a frame of a blank screen. How do you?
Right, they're being loaded.
Okay.
They're being loaded at the present time.
Great.
So they will appear on the screen very shortly.
Fabulous. So just, as Mark mentioned, this is really a great opportunity for us to be able to talk with you all today. And between myself and Dr. Juliana, we're going to go through some of the slides and really share some of the information from the changes and share a little bit about kind of what our vision is with these. And as Mark mentioned, that really this comes from a place of both Dr. Juliana and I have a long history of engagement with opioid treatment programs prior to coming to SAMHSA now about 2.5 years ago, or in September, it'll be 3 years. I was the medical director for an opioid treatment program in Baltimore City for 10 years. And really have, as an addiction medicine specialist physician, I've really spent my career taking care of people with opioid use disorder in a number of different settings, but predominantly in opioid treatment programs. Both experience with OTPs from Massachusetts and Maryland, and really have valued the opportunity to engage with other colleagues across the country, including at many ATOD conferences. And so, as Mark mentioned, this is also just the beginning of what we are anticipating is going to be several months of many opportunities for engagement, for exchange, for learning, for really helping to kind of put these and put the pieces in place, and really be able to work with everyone, from OTP administrators, OTP clinicians, state opiate treatment authorities, states, etc. So I think, with that, I am.
I can share screen instead if there's a problem loading. Angelina, I need you to take down the share. There we go. 1 second.
Yeah. And it is very exciting to also be able to see so many who have logged on today to really hear about this.
Just one moment more. I'm sorry, wrong screen to share.
Oh, no, you're good. You're good. It looks great.
Yes. Oh, okay, great.
Yeah. So,
Perfect.
So as Mark also mentioned, that kind of the gist of today, and that the focus is really on some of the general and administrative issues. So we're really anticipating that today we'll kind of go over some of what administrators and OTP administrators may want to particularly be aware of. And then next week, we will also then really be able to dive into some of the more kind of clinical and medical issues of the rule. So, I think one of the things that that we have, and I'm going to assume that everyone knows that it was published on at the beginning of February of this year, and that, as Mark mentioned, that the effective date is April 2nd. So what that means is that is the date on which OTPs can then really be able to start incorporating the new rules and the new changes into their practices, understanding also that obviously there are state components to this. There are also the accreditation body components to this, but that is kind of what the definition of that effective date is. The compliance date of October 2nd is then the date on which really from a legal perspective, kind of the anticipated the rules really then kind of go into and OTPs are then in full compliance with it. Again, understanding that there are state level issues, state components, as well as then also all the accreditation bodies. And that what we're really kind of talking about, and we'll talk a little bit more about this, is that the culture change that really we envision being part of the ultimate outcome of these rules, that also is going to take longer, because culture change often takes much longer than even just 6 months. We do envision that, and the rationale for these changes is that there really is an opportunity here for OTPs to enhance the services, improve collaboration with partner services, and really at the end of the day, facilitate medications and access to medications for opioid use disorder. As you all probably are very well aware, we are really living in a time of just an incredible opioid crisis driven by illicitly manufactured fentanyl and other polysubstance use issues that is really the worst that that this country has ever really seen, and that OTPs play an incredibly crucial part of the specialty treatment system for people with opioid use disorder and related conditions, and that the opportunity then to really be able to provide the care that people want to engage in, and also the need to then be able to help keep people in care and enhance that access to care, that is just more important than ever. We know that medications for opioid use disorder are also very underutilized, but they have an incredibly strong evidence base for saving lives and improving the lives of people with opioid use disorder. The next slide, please. So that just kind of highlights some of the underlying values and principles that we have come to and we come with that undergird this role. So really understanding that, you know, when there are individuals who have a chronic condition of an opioid use disorder, that very much similar to, you know, how clinicians and healthcare providers, practitioners engage with their individual patients in shared decision making, whether they have diabetes or hypertension or any other chronic medical condition, that really that engagement is so incredibly important. And that shared decision making of, you know, what is this treatment going to look like at this point in time, and how does it then change over time, is also a really significant kind of value and principle that we have baked into the role. What that means is that also this is now we're kind of trying to move away from what, you know, in some instances, and I think kind of historically, if you look really way back, you know, historically, that often OTPs were seen, and sometimes, unfortunately, there were instances where there was more of a punitive approach, and that was kind of a, you know, even a societal approach that really didn't have the science base to understand that when you actually turn that on its head and have care that is much more strengths-based, that is much more person-centered, in that shared decision-making mode, that is really then where people then see that value and can engage with their treatment in a way that then enhances any positive change that they also will then go on to make. That is not to say at all that you know, practitioner clinical judgment isn't important, because it absolutely is, and that it is that collaborative kind of nature between the individual and their practitioner that then you know, particularly when we're talking about controlled medications such as methadone, that is also you know, an incredible important principle that's also been baked into the role. Because we also know that, you know, making sure that practitioners can weigh those risks and benefits of medical decisions, whether that is with methadone or buprenorphine or, you know, hypertensive medicines or diabetes medicines, other controlled medications, that is really part and parcel of what healthcare providers do. That also then means that having responsive, flexible OTP services that meet individual needs of individual patients, that are then can change over time, is also something that is really baked in and undergirds kind of the values of what you'll see in the role. And we know that, as I mentioned, that there is an incredible evidence base for the methadone and for the services that are being provided and offered in OTPs. And so certainly the evidence base is something that, and we've learned a lot for over the last few years in response to the COVID epidemic and pandemic, that we've also baked into the roles, as we'll talk about a little bit in a little bit. And then finally, that, you know, I think the other piece of this kind of culture change that we're envisioning is really now that we know that there's a tremendous amount of stigma that has been associated with medications for opioid use disorder, and particularly with methadone, but that we are, as a field, we as you know, people who are really invested in taking care of people with opioid use disorder, that is something that we have an opportunity to help reduce that stigma. And so using non-stigmatizing language is something that you also see kind of baked into the role. Next slide, please. So as I mentioned, what we're really kind of trying to and envisioning here and trying to promote is kind of that culture shift in how care and services are delivered in an opioid treatment program in ways that foster trust and recovery in that patient-centered environment that is then, that can then provide an environment where there are responsive and flexible OTP services that are very much grounded in evidence. And acknowledging the skill and patient-centered understanding of treating practitioners. Some of the most incredible practitioners that I've ever worked with are ones that have worked in OTPs because they understand really the whole person and kind of the need to really address all the various different pieces from a multidisciplinary perspective as well. And that it's not just about a physician, a nurse, a social worker, a peer, a psychologist, but it's really kind of all together that really that whole person approach can and people can benefit from that as in an individualized way. And that ultimately what we're really trying to do is promote medications for opioid use disorder as a treatment for a chronic medical condition, and thus in doing so and really talking about this in a non-stigmatizing way and in a health-oriented way that hopefully reducing the stigma related to not only the condition, but also then the treatments as well. Next slide, please. So, so just to kind of dive a little bit further into like how we're actually envisioning that this would happen, right? That these are the principles, the values that that were infused throughout the rule, but what does that specifically mean? So one of the things that we have learned over the past 3 years with the flexibilities that came about as a result of the COVID pandemic is that the flexibilities for the provision of take homes that really has based on research as well as anecdotal experience, kind of clinical experience over the past 3 years, that there has been significant evidence that the sky didn't fall when those flexibilities were put into place. And in fact, there's research to suggest that methadone take-home related or methadone related overdose deaths really did not increase significantly relative to prior to the pandemic. And in fact, the retention and the ability for people to actually engage in recovery and recovery-oriented activities that has been supported. So that was evidence that really allowed us to make permanent those flexibilities, as well as change the criteria for those take-homes from something that has been very rule-based to really much more of a clinical judgment, kind of using that risk-benefits framework that I talked about. And as a result, it does allow some eligibility for take-home doses upon entry into treatment, again, really based on that clinical judgment and again, using that risk-benefits framework. But the time frame for really getting to not having to have patients come into clinic every day, that's also been very much shortened and allowing for people to then really be able to pursue the recovery and the goals that they have for themselves. What we also have done is to remove that participation in counseling as a contingency for medication access. I think one of the things that, sometimes has happened is that in order to, for example, you can't get your, there have been situations in which individuals have been told that, they have to come to a group every week in order to actually be able to continue on their medication. And because we know that the life-saving properties of the medication are so critical at this point in time, that also then helping people and having that individualized assessment of an individualized approach to a treatment plan, that that also then, both of those components are important, but really then taking them kind of separately from in terms of treatment planning, and the how treatment services are then provided. It does also continue to require the OTP to offer adequate treatment services. So again, we're not saying that it is medication only, but we're really saying that the offer of treatment services, counseling services, other types of services, the OTP is required to do that, and that really this lens of how do we engage people in treatment, in services, is then on the OTP kind of provider to figure out also what, with the patient, what is going to be the most helpful from that perspective. Next slide. And so additionally, if we're thinking about kind of how we're operationalizing this fostering trust and recovery in a patient-centered environment, so one of the other things that that in the Consolidated Appropriations Act in 2022, that was signed into law in December of 2022, there was a requirement that for SAMHSA to remove from the regulations the 1-year opiate use disorder requirement for adults for admission. And so we have incorporated that into this rule. We also have changed the requirement such that for individuals who are younger than 18, that previously there was a requirement that they had to have 2 unsuccessful attempts at withdrawal in order to be considered for admission to an OTP. Given what we now know about the increases in overdoses and overdose mortality among the younger population, kind of youth and transitional age youth, that also is something that we have removed to make sure that people then could have access to effective and life-saving therapies without having to have kind of those fail first approaches. It also, we've really tried to increase kind of access to medications and other services such that the changes really allow for patients to begin to get treated with medication, whether it's methadone or buprenorphine, after an initial screening exam. So really just being able to identify what some of the contraindications might be to starting those medications, really being able to actually understand kind of, is this the right medication for this individual? And then being able to start the medication with then the completion of a much broader and more comprehensive physical and behavioral health assessment occurring within the 14 calendar days following admission, and then periodically thereafter, so that we want to have that whole person approach and that comprehensive approach, but not necessarily have to have individuals sit through an hour, 2-hour long admission intake and history and physical on the very first day. It also revises some of the language for drug testing from really kind of catching people. That's not really the intent. The intent is to use this and drug testing as another data point and another kind of objective data point in the care of an individual. And so also making it much more strengths-based to then be able to say, look at how great you're doing. Look at how strong your recovery has been. Look at what the progress that you've been making. So so really being able to kind of use it in that way. Next slide, please. I think the other thing that we acknowledge and have incorporated in the tool is that, or in the rule, is that there are an incredible amount of skilled and professional, appropriately trained, competent, very experienced practitioners who work in OTPs and who have worked in OTPs for many years. And so making sure that we actually can acknowledge that nurse practitioners and physician's assistants as practitioners who are able to order and manage methadone, also in accordance with their state laws, that is something that now, really across the board is an allowable activity, and recognizing a scope of practice for those categories of practitioners. We did want to just point out that the medical director still must be a physician, but really everything else short of the medical director responsibilities really is something that nurse practitioners and physician's assistants, again, in accordance with their scope of practice and state laws, are able to accomplish. We also have incorporated that, knowing that, again, access to medications and treatment services now are just so vital given the dangerous drug supply, that making sure that we actually, also there are other practitioners external to the OTP. So whether that is a primary care physician, whether it's a hospitalist, individuals who, practitioners who practice in hospitals, that medical screening that allows for and really kind of describes the initial assessment of an individual that can help determine the appropriateness and the clinical indication for methadone, that is something that actually can be done by practitioners external to the OTP. It does mean that the OTP practitioner, so either the physician, the nurse practitioner, PA, needs to review those examination results, really kind of make sure that is something that they're also comfortable with and understand, but that then can enable individuals to start medication at that moment. And that the total dose, we've also increased that, again, kind of using some of that clinical judgment, and we'll get more into that during our time next week as well. Next slide, please. And then the other piece that really came about under the COVID pandemic was another way of being able to expand access to care, again, at a time when having to have people come in person was very limited because of the COVID concerns. And so what we have learned as a result is that, telehealth and buprenorphine in particular really can safely be started through audio only or audiovisual technology. And so we have made that permanent. The other thing that we also have included in the final rule is initiation of methadone using an audiovisual technology. Understanding again that really wanting to have that increased access to care, and that, but there is some difference between methadone and buprenorphine, kind of in the ability to really be able to see people before being able to start that medication. We're also incorporating a significant amount of harm reduction and recovery principles, kind of infused in throughout the role. We talked about the counseling and the drug testing pieces already, but really also having OTPs kind of look at and take a hard look at how do we keep people safe, especially as as they are stabilizing, as they are really engaging in services. How do we really kind of help to keep them safe during that period of time? Next slide, please. And then I think this is, Patty, this may be where I'm turning over to you shortly. But I just wanted to also say that, expanded access is, and, we know that medication units, mobile units, that is certainly something that SAMHSA has been very supportive of after the DEA provided their guidance a couple of years ago. And really just now in the final rule, making sure that it's clear that really the full spectrum of services are allowable on medication and mobile units, to the extent that there's also some private space. Also making sure that we've extended the use of interim treatment from 120 to 180 days. as another way of engaging individuals, expanding that access, but making sure that actually people can then move from that interim to comprehensive treatment during that interim period, so that they really then have the and can have the benefit of the offer of all of those comprehensive services. And then the other piece that we want to really highlight is that recognizing that long-term care facilities and jails that have that DEA hospital clinic registration, this is something that we also worked with the DEA on for the final rule, that they are areas that can dispense methadone for individuals who have an opioid use disorder when that is adjunct to a primary health condition, without having to have the long-term care facility or the jail actually be registered as an OTP or as an NTP. So it's another, now we're expanding the way that that correctional facilities really can think about incorporating medications for opioid use disorder. And so this is another tool kind of in the toolbox that we hope will really be able to expand that access. And then finally, just encouraging collaboration with other services. That is also something that we can talk more about. But that taking that comprehensive kind of whole person approach is something that that is also infused within the rule. Next slide, please. And
I think this one's for me.
I'm turning it to you. Yep, thanks.
Hi, everyone. Glad you're here. The next couple of slides will cover some of the changes to certification and accreditation processes. And then we'll share some of what we've been doing and will be doing in terms of assisting with implementation. So there was a lot of lack of clarity with the original set of regulations in 2001. Things not defined. SAMHSA was not used to, hadn't been accrediting programs or certifying programs or involved in the accreditation process at the time. Since then, we've learned a lot and have used this opportunity to enhance some of the ways in which the processes go underway and some of our work with the accreditation bodies. So for starters, there is time allotted for corrective action to be implemented that is defined in the regulations now. 180 days past the receipt of the survey report. We distinguish between minor and significant noncompliance. There was challenges understanding what was meant and what qualified for a 3-year and a 1-year accreditation or and following other certification issues. We introduced a 3-year accreditation for OTPs so that their certifications to allow for more of the minor. In the original rules was that line about one standard not being upheld or could result in 1 year. That's been corrected with these changes. We also implemented 1-year accreditation for those required to correct significant non-compliant conditions. The corrections must be made within a year. And then we added rules that detailed what we expected in terms of severe non-compliance. By severe non-compliance, we mean risks to patient and staff health and safety. So separating these a little bit in terms of categories of certification, there was a transitional certification that remained in the rules. That was the original going into accreditation and certification processes. That's now extinct. It ended in 2003. We established the conditional certification, which is a 1-year certification that basically would parallel the 1-year accreditation survey results. Once a program is a provisional certification remains, but once a program is certified, we expect that the programs will apply for renewal within within that last year of their accreditation period, but before the certification expires. So this language was clarified because despite the repeated notices to the program sponsors by both SAMHSA and the corresponding accrediting body, there still are delays in submitting requests for renewals. Those notices do go to the program sponsors, but the programs receive a notice, a letter that's, excuse me, that says when their renewal is due or when their application, their certification expires. So those are hopefully posted in the clinics and everyone can see when they're due. We do need them to come in before time. An extension, if there are extenuating circumstances that preclude an application from getting in on time, then an extension can be requested. There needs to be a justification. That said, it does happen that unfortunately some programs do lapse. We're taking that very seriously, and there should not be a time when a program is not operating with appropriate regulatory certification and accreditation and state licensing, renewal of DEA licenses. Those are part of the operations of an OTP, and they should be in place and current. In terms of our expectations of the accrediting bodies, we work very closely together. I'm sorry, we meet regularly. We do want the notices, we do want to receive notices if an OTP is it has some significant non-compliance. We expect response within 48 hours if health and safety is compromised. We ask that they are clear about areas of significant and minor non-compliance, so the reports are simpler for programs to address their needs and corrections. And then we expect the accrediting bodies now to verify that there has been corrective measures put in place. That's done historically as a follow-up, at the time of the next survey, but we have adjusted the timeframes for that a bit. In case of severe non-compliance of a program, we do expect to be notified promptly. And we will follow up, and as will the accrediting bodies. What do all of these changes mean for the opioid treatment programs? These are hopefully opportunities to expand treatment, how it's provided, being more flexible about care and able to reach all the more people. We recognize that having less frequency of take home, and for some people not having as frequent counseling or other services from the clinic, that will actually allow programs to see more patients. And hopefully these flexibilities will also improve retention and care, so expanding the numbers of people that can be served. We look to see more opioid treatment programs add on mobile units so that we can reach more people. And in terms of collaboration, we certainly are hoping that these will facilitate the reach of opioid treatment programs using med units, possibly collaborating with community-based mental health centers or primary care clinics to provide OTPs as adjunctive to their services. There's also the opportunity to fully integrate primary care, enhance infectious disease treatment and mental health services within the OTPs themselves because of these changes in many different ways. A goal of SAMHSA is to eliminate hepatitis, and certainly those services can be provided within the context of these changes. In terms of some of our activities, some our web pages have been updated, documentation of different aspects of treatment have been updated. We're right in the middle of the process of updating the opioid treatment guidelines to be in sync with and further explain the Part 8 regulations. We've already had several meetings. We've met with the SSAs, SOTAs, and state Medicaid directors on Monday to explain the regulations and the context for these changes. We have some meetings set up with the accrediting bodies, and this meeting today and then again next week. These are just the beginning. We do expect to have other other trainings and possibly some regional based meetings as well. And we have been working, we did an update with the CDC and FDA, the DEA. We continue to work with closely, Office of Justice Programs. These are just some of our partners, and we will be expecting more, and we'll continue that. So with that, I will turn this back to Mark for questions.
Okay, so
Share.
thank you both. That was a very helpful overview, and at the risk, and we've been joined by Dr. Arballo as well, so welcome. Again, I reiterate that this is a beginning, this is an evolution. And we've gotten lots of inquiries at our office about this, as you might imagine. And there are more than 800 people on this Zoom call as well, so it's sort of widely distributed. This is a lot to take in. I understand this, and I think we all understand this for that matter. And so like anything, you know, it's like a large bite out of a big elephant. It takes a lot to metabolize and digest, and that's going to happen. I mean, this has been a very thoughtful process, and I've said this, and I'm grateful for SAMHSA for this. This is going to take time to shake out. So let's do some questions. Given what you've said, there are a couple of questions about the roles of the SOTAs. So I know you met with them this Monday. I was on that Zoom. But the question for you is, have the SOTAs in the states communicated with you guys? And to the extent that you know, are they working internally with their regulations to be compliant by October? And the second part of this, how does SAMHSA envision OTP adherence to guidelines in states that may not be so quick to promulgate the changes in their own respective state domains?
Yeah, no, thank you for those questions. And Patty, I don't know if you, have some thoughts around this. I guess I would just start off by saying that we, certainly we anticipate continuing to work with the state the SOTAs. That we have an all-day workshop plan with them also at the ATAC conference. In fact, there are, there certainly are also kind of limitations to what we can do from a federal perspective. And as I mentioned, that there are then states also have their own processes and need to look at the new rules and new regulations kind of, at their own for themselves as well. So I think we've kind of laid out what the opportunities could be. And we've laid out kind of the vision for what we are and why we have implemented, and put forth these new rules. But certainly the states also need to take their time to look at them and make decisions as well. But Patty, I don't know if you wanted to add anything or
the only part you that we didn't talk about was the part about, do they recognize the changes that they may need to make? And several of them have acknowledged some of the changes that they might want to make or need to make. And some have said that they will be making requesting emergency level changes. So they are very well aware, and the attendance at the SSA SOTA meeting, state Medicaid directors, was very high. So most were there.
And
Okay.
yeah,
Is-
and just to add, really that working kind of with your state sodas, and with your states as well, that I guess is the other piece I would say, to the folks on this call as well.
And is it SAMHSA's position that if a patient refuses to participate in counseling, that they should be able to remain enrolled in the OTP indefinitely and just receiving medication?
Yeah, so I'm happy to take this one to start and then have others jump in. I think it's so this is where kind of that individualized approach comes, and having spent decades really taking care of people in opiate use disorder in OTPs, that there are certainly patients who, and individuals who kind of refuse to engage in anything, any kind of activities. But counseling isn't the only activity that OTPs have to offer, and that really then finding kind of those services that an individual is willing to engage in, that 9 times out of 10 that that typically can happen. And whether it is the person is willing to talk to a peer, willing to talk to a counselor, willing to talk to a nurse, willing to talk to a nurse practitioner, PA, physician. And I think that is really the beauty of having a multidisciplinary team in an OTP, because if it's not the counselor that the person is willing to engage with, and that often there are other individuals on the team that the person really is then actually willing to sit down and talk to. And I think it then goes back to the OTP, that really being kind of creative about how do you engage people in services that they then will find useful and helpful, and slowly kind of begin that process of even continuing to engage them in more and more services. So I think it's hard to really say, give kind of a yes or no answer to that question, because it really is very individualized. I don't know, Patty or Rob, if you wanted to add anything.
Thank you, Dr. Olson, and hello, everyone. My name is Robert Bailey. I'm a physician and senior advisor here at SAMHSA CSAT, and I apologize for being late. It's a divide and conquer day today. But certainly in follow-up to what Dr. Olson said, from a rule perspective, we recognize that individuals, wherever they are on the stages of change, may accept or not accept counseling, but the rule does support the OTP continually offering those services. So the services should be available, of course, and that means that the individual should be offered interventions and treatments in line with the patient's plan, the practitioner's understanding of where the patient is on their path to recovery, and try and engage them. And certainly counseling, like Dr. Olson said, is one aspect of treatment. There's other ancillary services, case management, family therapy, peer support, all those other elements that can help an individual along the way. So the rule certainly is not black and white here. It says that we recognize individuals may not want certain services at certain points, but those services should always be offered.
And I think that's really the key, that it is not that that we're not saying to remove any services from the offerings of the OTP. The OTP really is we want the OTPs to be able to offer all those comprehensive services. And so it is not at all removing clinical services from the program. It is, if you look at it from the perspective of the individual, that's where then really that individualized treatment plan, and how you engage that individual in those various different services, that's kind of where the innovation comes in.
Also, I think the point here is to provide progressive engagement to the patient. The issue here is not so much to compel people to deal with services that are offered, but to be sure that the services are available to the patients. So there's a certain distinction here. And certainly it's out of respect to the patient. And also it means for the OTP managers and administrators, you also have to be vigilant of how the staff really work with the patients. That's not embedded in the regulations per se, but that's more of an operational detail. And for those people who have certainly managed OTPs or directed them, as I have for a long period of time, you sort of understand this. Next question is, should OTPs interpret that they are not required to complete 8 randomized drug screens per year?
Bill, you want to respond to that one? Or Patty?
Your sound went out for a second, Ingvild, but there is a requirement for 8 random drug tests per year that remains in the regulations. And the part about the non-punitive language with allowing for extenuating circumstances, you referring back to what Dr. Olson had mentioned, those are not for gotcha purposes. It's not to find somebody doing something wrong, but to support and promote and validate their progress in treatment. So hopefully that answers the question. But while I have the soapbox for half a second, there were some questions about the research. All of the research that we quoted today are in the preamble to the regulation, the final Part 8 rule, and everything can be found there in terms of the documentation and support for this.
And that is a question about, with the NP and PA level practitioners, will they be able to order managed methadone in the OTPs, or do they still need to submit for a mid-level provider exception request?
No more mid-level exception requests, except for the state. It depends on the state's regulations.
From a federal perspective, there's no requirement any longer, but folks should check with their state and their scope of practice within the state.
Well, I think you've responded to this question at the beginning of your presentation. I think it's worthwhile to restate it, which is, can an NP serve as a medical director with oversight from an MD?
So the medical director does need to be a physician, an MD. So so the answer to that, I think, then would be no, if that's the question of an MP being able to be serve as a medical director. The answer is no.
Okay. This is about mobile units. Will mobile units be limited to surrounding area from the OTP location? In this case, meaning a 30-mile limit, and will the mobile units affiliated with the OTP be able to use the same DEA license as the OTP itself?
I think some states had some requirements about the range of travel of a mobile unit, and from an historical perspective, I know Nicole is on and can answer that question about the range limitations. But based on Part 8, there aren't those limits, except for practical aspects of needing to return to the clinic as a mobile unit. We have published the guidance for use of mobile units that are pretty detailed, and those have not been changed. We just absorbed them, so you can find the specifics on the website.
Also, keep in mind that in the final DEA regulations that were released in June of 2021, there is an opportunity, but it does require an exception request to the DEA. If the van, it's not practicable for the van to return to the home OTP, but there are certain security requirements that are there. So that opportunity was simply the result of, if the van does go out farther than it is practicable to return, then you can ask for an exception with the DEA. It's not, remember, it's a DEA requirement, not a SAMHSA requirement.
Exactly. Thank you, Mark. That's exactly what I was gonna add to Patty's response. So.
Okay, and let's say this is probably the last question that I see is, there's an expected time frame for when these new guidance are going to be finalized. And so what do you anticipate in terms of the October 2nd sort of completion date, so-called? So I think that's going to be subject to, let's see how this works over the next several months. I don't think you're soothsayers, but I think the issue is, what do you anticipate, if anything, in terms of how this compliance requirement is set?
Do you want me to take that? So April 2nd is the can. You can start applying these rules as of April 2nd. Yeah, that's the effective date. The must is October 2nd. And as you were saying, Mark, how this plays out is questionable. I think part of that question is about the states and the respective state responses. But the general rule of thumb is whatever is the stricter of the guidances is what needs to be applied. So if the state on October 3rd is still a more restrictive regulation, then that's what you need to comply with. One of the regulations is that the OTPs have to comply with all federal, state, and local regulations. So that can be a guidance if it's any help. We do think that these mostly speak to undoing and unlearning of traditional approaches to treatment, although most of the changes have been implemented during COVID. So hopefully that'll make it easier for everybody to adjust. And right now, I think we're in a phase of unlearning. Ingvald,
I think that's true, and it's time for us to conclude out of respect for the timing. And you're going to see us at ATOD really promote more mobile van use and more bricks and mortar medication unit use. And this is simply a way of extending the reach of the OTPs. There are only 40 such mobile vans in the United States. And I will tell you, I thought that there would be over 100 at this point. Maybe I was overly ambitious. But no matter what, I know there are other questions that were submitted. And so under agreement, I'm going to send all of your questions over to Dr. Juliana. She will certainly pass them along to her associates. And I think this has been very helpful. I will look forward to next Wednesday. And I appreciate your point of view with regard to how do we roll this out in a way that's meaningful, and frankly, as meaningful as the work you have already done in developing this final rule. I think the final rule is quite excellent, and I congratulate you, as I've done all along. So there's going to be a survey at the end of this, so you can give us some feedback, which will also be shared, and we'll notify all of the participants when the recording becomes available with slides. And if you want certificates of attendance, they'll be issued on request by sending the email to info@aatod.org. So thanks again for joining us and supporting these initiatives. Have a wonderful afternoon. And once again, we will continue with this. And I thank Angelina Budia on our staff for organizing this webinar. It takes lots of time and effort, and I hope you have enjoyed it. We will continue, and this continue for months before we get into the final implementation. So thanks again, very helpful. Look forward to next Wednesday. Everybody be well, enjoy the afternoon. Thank you to our speakers.